All right, so welcome back, everyone. This is the device implantation portion of the program, and we have our trusty device rep here, Taylor, who's going to help us navigate through this CRT implant. And so, do we have a patient history on this one too?
Yes, we do.
Okay, so I'm going to pull up the history.
Stuff here. So here's our journal.
Yeah. So can y'all see? Perfect. So this is a 70-year-old gentleman who had suffered an MI 2 years ago. He's on good medical therapy. He's a New York Heart Association Class 3 with an ejection fraction of 26%. His ventricle's enlarged. It's sick. And then when he comes into clinic on the ECG, he has sinus rhythm with a left bundle branch block. And so for him, the intervention will be a CRT with defibrillator. Okay, and so we are in the lab, and basically we use our standard venous access techniques. We've made a pocket, and we are going to go ahead and deliver the LV lead.
So you want a straight stylet to start? Or you want it angled?
Okay, so we'll do the RV first. Okay.
Yeah.
So let's just go with the curved one.
Go with the curve, okay.
Okay, and so typically, because these folks have left bundle branch block, we like to put in the RV pacing lead and defibrillation lead first, because if crossing the tricuspid valve you were to ding the right bundle, then you have complete heart block. Not that it never happens, and it's always exciting for us in an adrenaline rush, but we always like to get that RV lead down first. All right, and so here we are. Step on fluoro there. Okay, so this is our RV lead, and let's go ahead and get our curved stylet.
So that should be in there if you want to advance it.
All right.
You've got to go all the way.
And so these leads are like spaghetti. I don't know if you have samples for them to kind of pass around, but the only way we can steer them to get to where we want them to go, unlike angiography catheters, is to actually put a stylet that kind of gives them body and shape, and so we can actually fashion these stylets to give it a little bit of body.
If you need more of a curve, let me know.
Yeah,
it's just very tough.
Okay, perfect. And so we're going to go ahead and advance this across the tricuspid valve. Perfect.
Might be the CS.
Yeah, exactly. Good. Nice. And so it's always nice when you're placing the RV lead to make sure you can gauge the outflow tract, and you'll actually see, because it is in a very arrhythmic part of the heart, you'll actually see outflow tract PVCs to confirm that you're actually in the RV. And then let's go with our straight stylet.
Okay.
So we'll switch out for a straight, somewhat firmer stylet to be able to drop down from the RV outflow tract onto the apical septum. That's actually a decent spot.
Yeah, looks good.
Excellent. And so it doesn't have to be in the true apex necessarily. Actually, true apex is a little bit thin and you can perf. And so we like it somewhere on the septum. Can't perf on the septum is what they always used to say in school. And so a nice spot. As long as we have good electrical parameters, I think we'll be able to deploy the screw, fix it in place, and then move on with our LV lead implant.
So go ahead and step on X-ray. Just want to see the helix is extended.
Okay, so the helix is extended. And then does it give us numbers? Okay, so he's doing his normal checks to make sure that electrically we're in a good spot, that we can sense the intrinsic ventricular electrogram, that we don't have phrenic nerve capture at high output pacing, so make sure we're not too close to the diaphragm. And then also, obviously, pacing is important, so make sure that the pacing threshold is within acceptable limits. Okay?
Okay.
Good.
So, we ready to place this thing?
Great.
Okay.
So now let's go for the LV lead.
Okay, go ahead and pull it out.
So we'll pull that sheath out. And then typically we like to do the LV lead through a separate access point because we don't want to dislodge the RV lead while we're placing the LV lead. And so we got a second access point, put in another sheath.
All right, let me hold on one sec. Confirm this. Go ahead and pull that out.
Okay.
Yeah, there we go. Perfect.
Excellent. And for the LV lead delivery, what's really made CRT a lot quicker and easier to implant is the fact that we have these pre-formed guiding catheters that can actually provide support into the coronary sinus. It used to be that we literally, I mean, our attendings would run into the angiography suite or the IR suite and grab, the catheters they use, multi-purpose catheters and so on and so forth. But now we have preformed catheters that honestly I'd say 90% of the time, they hand off, whatever they hand off and it goes in. I mean, it's made the implant time a lot quicker. It used to be that you'd book 4 or 5 hours for a CRT implant because you never knew what equipment you'd have to send your tech running out to grab. But with the tools they have now, I mean, skin to skin, we're doing hour implants.
That's one of the outer sheets.
Okay.
You can see the screen up there.
Perfect.
We're filming right behind here. So okay.
Okay, and so we're ready to go in with our sheath. Okay, so we're back on fluoroscopy, and this is a coronary sinus guide sheath. As you can see, it has a sort of a primary and secondary curve on it. And the goal is, we know, now finding the coronary sinus is tough because it doesn't show up on fluoroscopy. A couple tricks that we can use is sometimes if a patient has a calcified AV groove, just like you're finding the right coronary artery, you can actually identify sort of the inferior portion of that annular calcification, and you can actually get to the CS that way. The trick that we typically use is if you can get the tip across the tricuspid valve, you can actually pull back and toward the septum. And again, 90% of the time, it will fall into the coronary sinus. And so that's what we're going to do. We're going to try to go across the valve, pull back, and we actually have a manifold here with contrast, and we're in the coronary sinus. Look at that. So without even really trying, we're in the CS. I'll kind of advance it up there. A little puff. And so we typically will do venography to identify the branches. Ideally, you want a posterolateral branch to be able to deliver the CS lead. And as you can see, and actually let's go LAO and RAO to show them here. We typically use multiple fluoroscopic views. And we'll talk a little bit about this in our didactics, but we know a lot more from randomized trials about lead position. So this is an RAO view. So you can see the catheter in the AV groove. And that's actually a very juicy posterolateral branch right there that's coming off. LAO can also be very helpful. Sometimes it's hard to tell in just one projection how lateral you are, particularly if it's AP or RAO. But LAO can help us identify the lateral branches. Actually, it's
tougher in that one.
Yeah, it's a little bit tougher. May need a little bit more LAO. Let's try that.
Yeah, there you go, maybe less.
Yeah, that one right there. So that one right there coming off is the one that will target right there. All right, so let's go back to, I think AP was a nice view there.
Yep.
And what we'll do is we'll use the over-the-wire technique to deliver the lead into that branch. So the lead actually doesn't sit in the main body of the coronary sinus. We actually wanted to get out that branch for stability and also to be able to capture left ventricular tissue.
We got the lead in here. We should be good. Cool.
Excellent. So we're on fluoro. We're delivering a lead through the sheath. The sheath is nice because it not only gets us into the coronary sinus, but it also provides support to deliver the lead. So
It pretty much goes all the way to the end, so.
All right, so we're a little hung up here.
Okay, there it is.
There we go, perfect.
I think you're still in there, yeah.
Yeah, and so we'll advance out, and there you go. Perfect. And as you can see, this particular lead has 4 poles on it. So this is the newer technology, quadrupolar lead, which is nice because you can actually pace from any of those 4 poles. So depending on where your lead ends up getting positioned, right now our distal tip is a great place to pace because you can see it's kind of lodged in that branch. There are other times where you may want to pace more proximally. And so the nice thing about the quadrupolar lead is that it gives you those options. There was a day not too long ago when we had unipolar leads. You could only pace from the tip. Okay. And so we'll have Taylor run the numbers.
Yep.
And for the LV lead, you want to make sure that A, you can capture the ventricle. And it's always nice to look at the QRS morphology to make sure that you're getting LV capture, so a nice right bundle QRS complex. And then because of the phrenic nerve anatomy, it's variable in patients. Actually, you want to make sure you're not pacing the left phrenic nerve because hiccups and phrenic stimulation is a complication of a poorly placed LV lead implant. And so you don't want to give a patient the hiccups when you're pacing.
So that's the RV and LV there, and we'll go ahead and place this one.
Okay.
So we'll place the lead and go ahead and pull it out.
Okay, so I can pull this out?
Yep.
Keep the sheath in?
Yeah.
Okay. And the sheaths, because they're braided, we actually need to slit them mechanically. So there's actually a razor that they give us, and we slit the catheter over the lead to be able to remove it from the body. You can't just peel it or pull it out.
Okay. So now we'll go with the A.
Okay.
So Eric, for a while we did echo optimization and all that stuff. And
Yeah.
that's really fallen out of favor. How do you know which lead to pace in terms of actual function?
Very interesting. I have an excellent slide on this in the didactic, but oftentimes we'll optimize things intraoperatively. And a couple ways we can do that is we can actually, with echo, what you want to look at is the desynchronous site, right? The segment of myocardium that activates the latest, because then if you pace it early, you can then synchronize the heart. You can actually do that electrically with a parameter called the QLV. So on the pacing analyzer, you can actually measure from the QRS onset to the LV electrogram. And there's in these patients with left bundles, there's actually a fairly long distance electrically between the QRS onset and where that site is activated. And so it's the site of latest electrical activation that we target. And the nice thing about the quadripolar lead is that if you're not getting it from one area, you can actually pace from a different area within that vessel that gives you the latest site of activation.
So you're essentially able to electrically do optimization.
Exactly.
And that's why we no longer do echo optimization.
Exactly. Now, there's some folks where if, for whatever reason, they have a suboptimal response, you can then bring them back for echo optimization. But the nice thing about this is that you can do it intraoperatively without the need for echo. Now, when I also assist some of the robotic implants that Eric Lehrer will do in the operating room, and he actually has TEE guidance. And so the cardiac anesthesiologist will get us an echo image of the ventricle as we're optimizing, because they don't, typically their patches are going to be unipolar, and so you don't, and obviously once it's sewed on, you can't really move it. And so typically we'll play with the timing, and before he actually deploys the screw, make sure that it's a site that's going to be late activating on echo. But in the EP lab, we typically have moved away from echo since, again, with the quadripolar lead technology and the ability to measure the QLV intraoperatively without echo, it's really more of a second line strategy.
Eric, I don't know if I wasn't paying attention, but how does this lead stay in place?
Very good. So the RV lead, as you saw, has a little active fixation screw. These leads actually are all passive. So basically the shapes are canted or S-shaped so that it actually hugs the vessel. And so without a screw, it's able to kind of stay in place. Now, having said that, depending on the venous anatomy, you may need a different shape lead because it isn't screwed in. So there's some branches that taper, in which case you can actually use a lead that has a taper on it with a little tine, so it'll kind of catch at the tip. The big juicy vessels, typically you want to cant, because what it'll do is it'll kind of hug the wall with the little bends. But you're right, it's not screwed in. And so in terms of the leads most likely to dislodge, I'd say LV lead number 1, then atrial lead number 2, because of just the anatomy and because of the fact that the LV leads are not fixed in place. And so, okay, so now we've delivered 2 leads. We're going to deliver the atrial lead now. And we'll come on fluoro.
Why it's doing that, but just a glitch in the thing.
And then do we have a J-shaped stylet we
Yeah.
can use?
So go ahead and feed that through.
Okay.
That should work.
So typically for the atrial lead, we aim for the atrial appendage. Now, if they're post-surgical, they may not have a right atrial appendage, in which case we have to get creative. I think we did that on Thursday. With you guys, actually, right? We had that surgical lady.
Oh, yeah.
Yeah, she did great. Didn't have an appendage, but that's okay.
Nope.
The nice thing about the appendage is that it is very pectinated, and so you actually electrically get great parameters. And And so we'll sort of deploy, this is actually a J-shaped stylet that makes the lead turn into a candy cane, and then you pull the hook up into the appendage.
That's the best J I can get.
Yeah, okay. And so let's deploy right there.
Okay. Okay. We are deployed.
Okay, and then have Taylor run his numbers. If it's in the appendage, typically you're going to get excellent P-wave sensing. The pacing thresholds are usually okay as well. Sometimes you have to move to the lateral wall. Sometimes you have to move a little bit lower down if you're not getting good numbers.
So that's A pacing right there.
Okay, so that looks like RV pacing.
Or maybe it's RV. Maybe it's LV, sorry.
Or LV, yeah. Okay.
Good.
Good. So we've placed our 3 leads. We'll suture them down to the pec muscle with our normal suturing techniques. And typically we'll run another set of timing parameters. They have a proprietary system called Quick Opt, which actually is able to optimize the timing on the atrial to ventricular lead, the RV to the LV lead. And again, you know, we used to do this all with echo, and now
Right.
with the ability to measure intracardiac electrograms and some of their proprietary software, we're able to do this all before the patient, you know, gets off the table.
Right.
And so successful CRT implant, he'll spend the night in the hospital, he'll get an x-ray to rule out dislodgement, to rule out any complications like a pneumothorax, home the next day, and then typically those patients will get an echo at about 3 months to assess for reverse remodeling. So we'll look at the left ventricular end diastolic volumes and systolic volumes. We'll look at obviously ejection fraction. But more importantly, we'll look at how the patient feels, because the symptomatic improvement sometimes is above and beyond what you get with just the EF. 6-minute walk is sometimes used, functional status, we know improves obviously, so our class 4s are moving to class 3s, our class 3s are moving to class 2s, our class 2s are staying out of the hospital. And then, you know, if there is any question about the improvement, or if there's a question that they haven't improved, we'll typically then bring them in for an echo optimization where we'll look at things, and honestly, we'll look at everything. We'll look at their meds, we'll look at any other arrhythmias that can be contributing, and then oftentimes they may need a reprogramming of the lead. Very, very rarely, particularly with the newer lead technology, do we need to bring them back to the EP lab, but it used to be in the area of unipolar leads that they'd often need to get their leads revised if we thought it was in a spot that was providing suboptimal CRT. Any questions?